Today, I'm joined by a person who's become very familiar to us all during the COVID-19 pandemic, Professor Catherine Bennett. Lovely to see you, Catherine. Thanks for taking time out of your very busy schedule to be with us today. I'm sure you'll agree the last 18 months have been an extraordinary time for health in this country during the pandemic. Just when we thought we might be getting back to some level of normality, we find the Delta variant now on our shores. Is the end in sight?
Great question, Kate. It's a question on everyone's lips. It is a changing challenge, and I think you're absolutely right. You know, where we've built some experience, we knew we were going to keep having outbreaks. We just didn't know the outbreaks would get harder and harder to manage with this shift in the variants. We knew it could happen, but it's different, the reality when you deal with it. What we've seen in this middle part of the year is both two things, important things. One is the emergence of a plan, so that early phase 4 plan that we've had laid out is a really important development. That takes us from trying to hold where we are for as long as we possibly can to reminding us what this is all about, which is about building our resilience and our protection to the virus in the community with vaccine and trying to keep ourselves safe as we can till we get to that point. What we're dealing with now, I guess, is the reality that we don't have all the time in the world to do that. And the change in the virus really pushes the agenda. You know, it means you've got to work so hard to build on resilience whilst we're still trying to manage our international border and keep the virus at bay. So those two things actually might work together in a way to help, I guess, Australia realise that we are as vulnerable as we are, and unlike other places in the world that have gone through some pretty terrible waves and that's motivated vaccination, we not only don't quite have that motivation level, but we also don't even have the natural resistance in the community from having large waves of infection. So we are vulnerable, and I think we just need to work on that as quickly as we possibly can, because it's going to get harder and harder to hold the borders. Only, a couple of weeks ago I started saying that the Delta variant, the one that's challenging us across the globe now with that being the dominant strain, it really does sort of spark the beginning of the end of COVID-0.
What do you think we could have done better during the pandemic?
I was having a conversation just today about some of that messaging and it is that sense that if you can show what vaccines prevent you from dealing with, it helps people understand the true benefit, and that's what they're weighing up. And I think, we've put our focus on you model to see what level you might get to get not even herd immunity, because we're not aspiring to that, a very kind of confused way about thinking sometimes around the benefits in Australia versus something as blatant as how many deaths have been prevented. So the communications and the coordination across the country, and then with that you get the politics coming in and enveloping the science and the conversation. And I think that's actually made what was perhaps our weakness a greater weakness. And that's disappointing, because we can't afford that. We've got to be looking at any outbreak in Australia as an Australian problem, and it hasn't been the way we've dealt with that as we've found these, state to state outbreaks. So epidemiology is about a very frameworked way of thinking that allows you to go through and interrogate numbers and see what's driving those numbers, and then understand what you can appropriately interpret from those numbers. And too many people now are armchair epidemiologists or number crunchers, and including people who are from health backgrounds. It's actually a skill set that we build up over many years. But unfortunately, people take shortcuts, and then things like that become viral because it gets reported by someone who's just looked at the numbers and didn't get it, but speaks with authority, who might be a physician. And then it just gets picked up and people throw it around out there. So how you get a consistent message out and how you put it out in a way that allows other people to share that, to be informed themselves or to pass your message on is critical. And so mainstream media, very important for reach.
Catherine, in addition to the role you've played in terms of educating the public, what role have you played in educating the government?
So I think one of the lessons here is something that many people have been asking for 30 years now, is an independent body that brings together the expertise, that has a way of doing that, both virtually and in reality, that supports government at all levels in its public health response.
As you say, public health has really enjoyed a bit of a time in the limelight. So once the pandemic passes, fingers crossed it will, and we will get to some level of normality again. What do you see as the key areas for public health investment?
We've learnt that we'd stripped away resources, particularly in public health. We've invested at different times in prevention, but we did some of our primary responses in public health really have been underfunded over a period of time, and that means you lose capacity. So one of the most important things is we take advantage of the capacity we're building. I know at Deakin we've got people who've come into these new roles being developed in government departments, and they're now coming back to university to do more training in public health, which is brilliant because you'll build up a group of people with experience and formal training that hopefully will have well-funded places in our public health going ahead, because you just can't build these things in a crisis. You have to have that there, and it's more likely to give you a stronger prevention position, and that's ideally where you spend your public health money, in prevention. But equally, you can then turn that into a response if you need to when you're confronted by these new threats. I think the other area that's really been highlighted through all this that needs attention is governance. So I alluded earlier to the idea of having a national centre to coordinate the information that comes in from other countries, that goes out to other countries, that feeds into the states. It has to be independent of government. It's got to be something where you can separate out a whole lot of factors. But at the same time, I don't believe you should just be looking at health in its own right. I think the other area of investment is what a lot of us have been talking about for a very long time, and I think, very good examples at Deakin actually of system science in health, so that when you look at a response, you consider all the other equal and opposite reactions you might get when you have an intervention you put in place, but to consider the bigger picture. And there's a sense that, if you put a particular package of lockdown in, you can't evaluate it, but that's actually not true. You can look at the shifts in the various transmission patterns that you see before and after. You know where the weak points are in a lockdown because you still see transmission occurring. So you can figure out what works and what doesn't work, and you should be finessing it. But for us in Australia, we kind of ramped it up rather than finessing it. Every state in Australia and territory has approached it differently. So we've had people who've had states where with a very small trigger, they've gone into a 3 or 5 day lockdown. But they might do that at a city level. Another state might do it statewide, and you can't understand the difference. And that, to me, is just a marker that you don't have good science to be confident or to do the same consistent thing each time. Each state has a slightly different risk profile, but a lot more of it seems to be risk tolerance than actual risk that determines these differences. And risk tolerance comes back to trusting the information that sits behind the recommendations or what they've seen done in other settings.
And how likely do you think it will be that we get a national think tank independent?
I think having something that is, again, independent from government, but brings together the expertise from across government and universities and private institutions, and our wise retired dons. I've heard from a lot of people who are great thinkers in this space, and they don't have a formal way to engage either. And I just think, that would be a great legacy for a health minister, wouldn't it, to pull that together, to say that this is the turning point. And Australia, which went from being, I think everyone would agree, one of the envies of the world, now people less certain about what Australia is doing and why, could in fact re-establish itself, as one of the leaders in this space if we really work together to analyse where we've been and what we can take from that into the future.
Catherine, as an institute, we're very interested in the social determinants of health, and I think through the pandemic, the link between economic outcomes and socioeconomic status and health outcomes has been really laid bare. What can we learn from this?
Oh, that's such a big question.
I know.
And I think that's one of the things we absolutely have to look at in the data we have already, even to fully understand what the impacts are. Eugene Athan and his group at Barwon Health and some of us across the Institute have worked to look at that in second wave data from the region, because we know that people from low SES groups are overrepresented amongst cases. But it's actually incredibly complicated. I mean, it was one of the things that I felt most frustrated by in a really personal way, I think, was the way people referred to the northwestern suburbs as the belt in the second wave of Victoria that saw most cases. And there was a lot of blaming and shaming. And we've seen the same happen in Sydney with, the winter outbreak of focusing now in the southwest, started in eastern suburbs, moves to the southwest, and then the conversation changes about, the people and their responsibility and not or helping or whatever. And the reality is, from a basic epidemiological point of view, that you combine a whole lot of factors, which can include language difficulties and cultural differences and perceptions and trust in governments and a whole range of things that influence how well messaging works and how relevant the messaging is to a local community, right through to the fundamentals of how many people live in a house and how households interact. And we didn't actually look after our casual workers in their jobs. The fact that they had multiple jobs meant they had multiple exposure sites. So if they worked across, 5 different facilities in a week doing the cleaning, they had 5 different opportunities to contract the virus and then take it home. And they were more likely to live with a number of other people, including other people in other casual work. So they would take it back to multiple workplaces as well. And that's how you get that dynamic. So they're a group in our population that are overrepresented in our lower SES areas, overrepresented amongst our culturally and linguistically diverse population. They were the people most hurt by the COVID outbreak. And they were the people that, time and time again when we had waves, had to go the hard yards to pull something back in that was foisted upon them. This is nothing anybody deserves, but it's harder work to close it down in those settings, and yet they did. So I just think they're amongst the heroes in all of this. And I do think, as I said earlier, states working together is so critical at these times, and yet you see more fracturing sometimes, and more I call it weaponizing of epidemiology, where facts can be pulled out, but they're used to support your case and push someone else's approach aside, and it plays out in a different kind of way, and it damages, how epidemiology itself is seen in these settings, if in fact it's being kind of used rather than actually listened to and a kind of a cornerstone to what we're doing and what we're learning about, how we move on from here. And so we've had a whole lot of things that have really increased divisiveness. But I still think the hardest one is the one that really pushed people into either fully supporting something like a lockdown, to the people who thought it was complete overkill and unnecessary, and a lot of confused people in the middle with the messaging that was going on. Early on, in particular, there was a lot of talk about the virus that then would temper down. This variant's faster than the other variant. Okay, it's not. But the time it looks like that, because that's what the outbreak responders are dealing with, and they always see the quick transmission first because it happens quickly. They sort of lose track of the people that don't actually develop their infection for a full week and a half because they've had to deal with that immediacy. But they're communicating it to the public in a way that ramps up the fear in the community who's saying lockdown at any cost, and then actually makes the people who say lockdown's overkill even more angry because they see that as overstating the problem in order to justify lockdown. So we did have a lot of confused people in the middle. Some of them gravitated to one side or the other because they felt they had to be somewhere. But a lot of that middle conversation, which was where it really had to happen, the truth always sits in the middle, and it's actually pulling people in from both sides. And I would argue, of course, as an epidemiologist, that the science around what works should have been central to that conversation. You could say the same message and I could be slammed, as the media like to say, slammed by both sides. Not people saying, what does that science evidence say today, and how do I take that back to my narrative, or how do I join that conversation in the middle to see whether we can shift our thinking? There was very little of that. It was either you were, held up as the person who was leading the charge on masks good or bad, you know. And so that to me was what we lost in all of this, the ability to come together and really solve the problem together and move with the changing evidence together. It became political even at that level. I think you lose a lot if you can't have those conversations. And I stuck to them and had a following of people who would write to me literally every day from all walks of life, you know, vice chancellors through to 11-year-old kids stuck out on a farm at the edge of Melbourne, you know, but inside the Ring of Steel, helping me understand how this appeared to people, how they experienced it, and how the messaging was translating to people. And so, you know, I thank all of those people, because this wasn't just my voice, you know, that I tried to stay with the data, but I was also learning from these people that took the time to share their analysis or share their thinking or ask me questions that then told me what we needed to be thinking about in terms of comms, trying to get out, you know, another opinion piece or whatever that would help unpack some of those questions. But at the end of the day, we've got more questions than answers. But as an academic, that's a great thing.